So our next speaker is Prof. Chris Beyrer from the Duke Global Health Institute. He's a physician and epidemiologist with extensive experience of issues of health and human rights. And through his work on HIV and as former president of the International AIDS Society, he has been an advocate on how social conditions shape both risk of disease and access to care. And that's what he'll be talking to us today about in the context of One Health outcomes. So thank you.
Well, thanks very much, and good morning, everyone. I'm delighted to be here. This is my very first One Health conference, and I want to say that you all are really doing extraordinarily exciting and important work, and it's really wonderful to be here. I want to thank the organizers for the invitation to speak, and especially our host, Sing Health, and the Duke-NUS. This, of course, is a closely affiliated institution with Duke University, where I am just very recently appointed as the director of the Duke Global Health Institute. So my first time visiting Sing Health and Duke-NUS, and really wonderful to be here. So I wanted to talk with you about the social determinants of One Health. And I think that the social determinants, as we have seen, and actually Anders Nordstrom just set this up beautifully, really play such a critical role in the whole One Health area, and certainly in pandemic emergence. And what are we really talking about with social determinants? Well, these are the non-medical factors, so putting medicine aside for a moment, that influence health outcomes. And these are really the conditions in which people are born, grow, work, live, and age. So sort of the social conditions that surround all of us. And these, of course, include economic policies and systems, development agendas, social norms, but very importantly, social policies and political systems, right? And this has been said in a much more poetic way by the French writer and physician, Marcel Sandrial. Each nation, by its customs, its laws, its principles of thought, creates for itself a pathology appropriate to itself. A society chooses its diseases and shapes its pathological destiny. So I think some of us would argue that in the case of COVID-19, that this perhaps overstates the case, but nevertheless, the ways that societies responded and the social determinants in those societies had a huge impact, as we've just heard, on the pandemic outcomes. So these are sort of the classical social determinants of health: education systems, the healthcare system, the built environment, economic stability or instability. And I think that what has changed for all of us and what we've understood is that now these social determinants of health are all happening within the context of the climate crisis, right? And that changes every one of these and has an impact on all of them. So I was fortunate to serve as a commissioner on a recent Rockefeller Lancet commission that was really meant to establish and try and be a foundational document for this new field of planetary health. This was our commission report, Safeguarding Human Health in the Anthropocene Epoch. A deliberately scary title, it must be said. And this, I think, was really an important foundational effort, and I want to just share a few of the outcomes with you because I think they're very relevant to this issue of the social determinants. And of course, when you do one of these Lancet commissions, as some of you will know, Richard Horton, the editor-in-chief, typically does an editorial. This is from his editorial. For humanity to achieve planetary health in the face of increasing demands for resources, while addressing unequal, unacceptable inequalities, will necessitate the development, implementation, and assessment of integrated policies to address the social, economic, and environmental determinants of health. And I think that that is absolutely spot on. And there emerged very quickly, and this is from the report itself, a paradox. And this is something of a human health resources paradox, and that is essentially that human health in the last decades has been dramatically increasing, life expectancy has been increasing, child survival has been increasing, maternal mortality declining, while we have been degrading the environment and the environmental systems and resources that human health and animal health depend on. So what is the basis of that paradox? Well, fundamentally, what it is that we have been mortgaging the health of future generations to realize economic and development gains in the present in unsustainable ways and ways that are highly inequitable. And I'm going to talk quite a bit about some of these inequalities because I think they're fundamental to the social determinants. And of course, all of that is happening in the context of the other reality, which is that there have never been more of us, and the human population has been increasing perhaps more quickly than almost any other determinant of economic and social life. This is from the Lancet report, and what you're looking at here is total population and urban and rural population, and you can see the urban population is the red curve, has surpassed the rural population, and even in what had been the most rural continent, Africa, several years ago, we crossed this threshold, and the majority of Africans are now urban or peri-urban residents as well. And this, of course, has put enormous demands on natural systems. This is, again, from the Commission report. The top left-hand, very, very steep curve there is population. I know this is probably hard to see for many of you. I would just say that the very next one with that lovely falling curve, you might be wondering, what is that? That is poverty. So we have lifted an enormous number of people out of abject poverty, which is an enormous achievement. Actually, probably China has played the biggest role in that by lifting hundreds of millions of people out of abject poverty. But that has meant that as there are more and more of us and we are less and less poor, we are using up this planet's resources more and more quickly. So what does that mean? Well, ecosystems, of course, we use the term services, provide an incredible array of services to life itself, right? And these are across a number of domains, obviously food, fresh water, air, very fundamental elements, but also cultural elements like recreation and spiritual elements of what nature can bring. And they also, of course, provide sustaining and supporting aspects for life itself, like habitat and like climate modulation, genetic diversity, all of which are now, to some degree, under threat. This is a model looking at those hazards and threats, again, from this Commission report. And I would just highlight that one of the areas where there is the biggest impact, and this is now what I'm going to focus on, is also what Anders was talking about, which is the issue of the political determinants of health, the social determinants, and the governance issues in health. So just before I do that, I do want to say, this also is from the Commission report, that one of the things we have all learned as people living through COVID-19 is that there's been an extraordinary burden of mental health. And I think perhaps we were unprepared for how powerful the mental health impacts would be, particularly for children and adolescents. And this is a meta-analysis that was included within the report on looking at the psychological and emotional outcomes from exposure to natural versus synthetic environments. And I think it's really quite extraordinary that natural environments have such positive impacts on mood, on well-being, on attention, and in reduction of negative impacts like anxiety, depression, and sadness. That's actually where you get into the realm of statistical significance. Statistically significant decreases in sadness. You think that wouldn't be important, but actually it is hugely important in the mental health crisis. And so this is another aspect of what nature gives to us and brings to us that we have to preserve for human and animal well-being. So I said I wanted to talk a little bit about the inequities and the social disparities. I'm going to turn to my own country, the United States, where we actually have quite good data on this. And just to say, a recent report from our Environmental Protection Agency showing the disproportionate impact of climate change on socially vulnerable populations. And just as an example, that Black Americans are much more likely to be in polluted environments with increased asthma exposure, and Latino Americans much more likely to have high participation in weather-related occupations and to have much higher heat exposures due to the fact that so many work in construction and agriculture. And those are just two kind of sharp examples of what we mean by social determinants, right? Everybody's living in a changing climate, but these are the people who are facing the greatest vulnerabilities to health. And that is also true for pollution. Unfortunately, it turns out in the United States that the best indicator of whether or not you live near a hazardous waste dump is race, right? It has nothing to do with people's proclivity or interest in living near hazardous waste. That has to do with the very inequitous nature of how we handle hazardous waste. So I have worked in my career really principally on 3 pandemics, HIV/AIDS for the first many decades, COVID-19. I was the senior scientific liaison for the US COVID vaccine prevention network, working on the COVID vaccine trials, and then most recently on monkeypox. And I just want to, share several reflections about how the social determinants have played out in these 3 pandemics. And first, obviously, to say, especially to a One Health audience, these are all viral zoonoses. They are all rainforest origin pathogens. They're all, of course, became emergent human pathogens, and they all became pandemics. The emergence, of course, in all 3 cases was associated with species spillover. We know that, and we're getting a handle on what the species were in each case. The pandemic outcomes, however, are profoundly affected by the social determinants, right? So after the spillover comes the pandemic, and that is when human society interacts with these outcomes. And I would argue that the pandemic responses, therefore, really have to include addressing and thinking about these social determinants and thinking about the inequities that are so inherent in our global systems. Again, I'm going to turn to the US because, unfortunately, my own country is such great, painful examples of this. This is from a brilliant Lancet paper. Patrick Sullivan, who's here in the audience, led for a special issue of the Lancet that we co-edited together. And what you're looking at here is a density heat map of the continental United States. The darker the color, the higher the HIV burden. And this is very specifically in our most highly affected population, which is Black, African American, men who have sex with men. And you can see this extraordinary, dense concentration in the south and southeast of the United States. Sorry to say, my new home state of North Carolina is one of these, and my former state of Maryland with Baltimore, where I was at Hopkins, is also one of these. And that is an extraordinary, iniquitous-looking map, right? So how do we explain that? How do we understand that? Well, we teased out and separated for a separate analysis Black versus white gay men in the United States. And what you're looking at here is the incidence curves, estimated incidence over time. For white gay men, you're seeing that nice, steady decline. That is what we want to see. And that is associated with a range of technological and medical innovations, the first of which was the understanding that HIV treatment has a big prevention impact. That was an important trial. That was followed by pre-exposure prophylaxis, another powerful intervention that led to further declines. And then we implemented HIV self-testing in our country and made self-testing widely available. And when you put those 3 elements together, you get a declining epidemic, which is just what we want to see. But look at the curve for African Americans. Anybody see a decline there at all, right? It's absolutely flat and high. And what that means is that over time, this is a health disparity that is widening, right? So widening health disparity. And if you look at the individual level and say, why is that? Immediately, many epidemiologists in the room will be thinking, well, those must be riskier men. It turns out that white men report more partners, less condom use. They're more likely to use substances when engaging in sexual activity. None of this is explained by individual level risks. However, when we look at social determinants across that same population and geography, and this again is Patrick's really brilliant analysis, what you see is that the social determinants are really playing a huge role here. So these U.S. states in the South, these high-burden, dark places, including, of course, Florida and Texas, very big and important, very conservative states, what you see is that these areas are less likely to have expanded health services, Medicaid services for the poor. They're more likely to have health provider shortages. They are more likely to have low health literacy, so there's less health education, and they are much more likely to have high stigma surrounding HIV infection. And what you're looking at here is, for example, on the far right, is the Gini coefficient, the measure of income inequality. And you can see very clearly that HIV burdens are sharply associated with sharper Gini coefficient differentials with higher income inequality. So this is not about individual risks. This is entirely about social determinants, despite the fact that it's the same virus, the same risk group, and really the difference here, unfortunately, is the inequitable nature of our society. Now, I would also point out that, of course, with the emergence of SARS-CoV-2, we saw some early social determinants playing out. This is at the local level in Wuhan. Many of you will remember the name Li Wenliang. He was an ophthalmologist in Wuhan. He was one of the first people to identify what came to be known as COVID-19, SARS-CoV-2. He texted on private social media chats to his medical school colleagues saying, I think we're seeing a reemergence of something like SARS, right? That was picked up by the local authorities. He was hauled down to a local police station. He was told to cease and desist. He was not allowed to put that information out further. And as a courageous healthcare worker, he went back into the hospital, continued to care for patients with this emerging disease, and was one of the early deaths from COVID at age 34. So we all know you never get back that early period. And of course, this local official, and we see it broadly, and I'll show you a couple of more examples, political responses to this outbreak have cost us all. Cambodia is another example. This is a report from Human Rights Watch. So one of the things that has nothing to do with pandemic control is arresting opposition political leaders, right? This is what Cambodia did in response to the outbreak, and of course punishing people who were putting out information or trying to get information out to the Cambodian public. And Human Rights Watch basically put forward this report saying the Cambodian government is misusing COVID-19 outbreak to lock up opposition activists and others expressing concern about the virus. The government should stop abusing people's free speech rights and instead focus on providing the public with accurate and timely information. I think we all totally agree with that. Unfortunately, we had a very similar situation in the United States. We lost that early period. This is exactly what Anders was talking about in terms of what the panel identified. And many will remember that early on, the president was actively promoting disinformation and misinformation, including about the efficacy of hydroxychloroquine, which of course turned out to have no efficacy and to be harmful, led to shortages of that drug for other diseases, and a number of statements for which he was actually charged, which included things like anybody who wants a test can get a test. This was when testing was not available hardly at all in the United States. The United States has tremendous control. This was before we lost 1 million lives and counting to COVID-19. And of course, one day this virus is going to disappear. It's a miracle. It's just going to disappear. As we all know, that has not happened. It's still not happening. I want to turn to the third epidemic, which is monkeypox, and which has now, of course, been declared a pandemic, emergency of international concern by WHO. Just recent data from November 4th, over 78,000 cases now. 109 countries, only 7 of which have historically had endemic monkeypox. So this is really an impressive spread. Again, it's a heat map that you're looking at here. But I think it's important to point out that the demographics of this current outbreak are really radically different than the endemic, as we all know. It's 95% or more men. It is a median age of 34, so that's a very different age distribution. And among the cases with known sexual orientation, it's 87% men who have sex with men, 5% in men who have sex with men and women. And among those with a known HIV status in these cases, half are living with HIV. So this is an incredibly concentrated epidemic in men who have sex with men. It hasn't always been characterized that way. I just want to take you back to the United States, unfortunately, for another bad example. And what you're looking at here on the left is the distribution of monkeypox cases by race. It's basically a third in black men, a third in Hispanic, and a third in white. And then that middle column is monkeypox vaccination. And what you can see, the dark blue color is white Americans, that we have a disproportionate vaccine access for that population, and the lowest vaccine coverage is in black Americans. So the disparity that I showed you in HIV, which actually took 4 decades to develop, was replicated with monkeypox and monkeypox vaccine in 2 months. And that tells you the power of social determinants, how lasting they are and how impactful they can be. Now, I just want to move to the last moment to say something important, I think, about conflict, because conflict is arguably the most important social determinant of health and well-being. As we all know, we are living in a world of multiple conflicts. Some of them, like Ukraine, we're all paying a great deal of attention to. Others, like the ongoing conflict and humanitarian crisis in Yemen, have really fallen off the map. But nevertheless, Yemen, over 200,000 deaths so far, and counting, a total disruption or very near total disruption in health services and food security, the built environment. We have to remember that when we think about social determinants and political determinants, humans are destroying each other's built environment aggressively and actively, and contributing, of course, to extraordinary suffering. I have done quite a bit of work with colleagues in Human Rights Watch on the crisis of the Rohingya. You probably know that the Rohingya right now have the largest refugee camp in the world. That is in Bangladesh, very close to here, Cox's Bazar on the Bay of Bengal. The latest challenge for the Rohingya is that they're being moved out onto an island, Basan Char, in the Bay of Bengal, that isn't actually even land a significant part of the year. And this is understood as an attempt to force them back into Myanmar, where their security is not assured. So just to say that in this region as well, these kinds of conflict determinants still play a huge role. And these people are also arguably now climate refugees, in addition to having to flee. The world, unfortunately, is full of conflicts. This map is already out of date because it doesn't include the conflict between Russia and Ukraine. But nevertheless, as you can see, many of the places in the world where we're most concerned about One Health outcomes in sub-Saharan Africa are also fraught with conflict. So I think what I'm saying, and what I'll bring this to a conclusion, is that we really need to rethink the social determinants of health. We need to put them front and center, and we need to do so in a way that really changes our relationship to animals and to nature in very profound ways. This is from Mark Friedman, who's also here in the audience. It's an impounded bat brought into the United States just recently from the CDC. This kind of relationship to animals has really got to change. I'm going to share with you a more beautiful image. This is from the 6th century AD. It's from the Duke Museum, and this is the Mayan bat deity. You can see a beautiful representation of the animal and a representation in art and culture. And I think, this is perhaps a positive icon to leave you with. The very last thing I will say is that a great mentor of mine, Archbishop Tutu, was very concerned about climate change. It was the last thing he was working on before he passed just last year. And I think this quote really summarizes, in a way, the human challenge we all face. Science has spoken on the urgent need to tackle the challenge. Now is the time to listen to our consciences. There's a clear moral imperative to tackle the causes of global warming. We're part of nature, yet we alone can act. Our destiny must be as guardians of the earth, not users and abusers of the only home we have. We all have a responsibility to learn how to live and develop sustainably in a world of finite resources. We must make peace with this planet. You're here. Thank you for your attention.